we've learned a lot in being part of this. And I have to say how I came to this work actually was through Sandy Sufjan, who was kind of a colleague and friend of mine when I was at the University of Illinois and was always asking me questions about hormones and cystic fibrosis. And I have to say, as a family physician, cystic fibrosis is so complex that we actually don't see it a lot in primary care. And so it's been a tremendous learning experience being part of this collaborative. And I'm just so happy that we've been able to bring sexual and reproductive health to focus for women with CF, because clearly it's been a neglected area for a long time. So I just kind of wanted to start with this first slide. And again, it's geared towards people who otherwise don't have a chronic disease. And it's a busy slide. I mean, in part because I think, you know, the sort of the overall health picture for a woman is very broad. And those with cystic fibrosis, it's even, but just kind of focusing on the fact that for those of you, you know, you see your cystic fibrosis provider in the clinics, and the clinics are very comprehensive. But I think one area that Laura was sort of highlighting when she invited both Sheila and myself to speak to you today was kind of the piece that seems to be missing in a CF clinic is the reproductive health, or the sort of women, so the components that are unique to women. And so in the slide, you know, just kind of pointing out that through the life cycle, menarche is sort of when a woman starts having periods, and then, you know, just thinking about things like contraception and what's the menstruation like, and are you having, you know, symptoms before or after your period? Do you have a lot of pain during your period? What about sexually transmitted diseases? And then, of course, at some point, women, even those with CF, are having to think about, well, do I want to become, you know, pregnant? Do I want to become a parent? And how will I go about that? And so those are other issues that sometimes are not addressed in the CF clinic. And then, of course, as women move out of their childbearing years into menopause, and what are all the symptoms that tend to go along with menopause. And of course, those with cystic fibrosis, the decreased bone mass often starts much earlier than age 60, especially since the lifespan is kind of more towards 50. So a lot of things are already happening at an earlier age. So hyperlipidemia, so the liver disorders that go with it, and of course, diabetes and all the complications that occur with CF-related diabetes as well. So there's a lot of complexity that I think, you know, that a provider needs to keep in mind if they're going to care for a woman with CF, and really understanding like what's unique to cystic fibrosis, but then what's also not being addressed in the CF clinic. So, you know, when Sheila and I were talking about this, in terms of shopping for a women's health provider, and I know for myself, I'm looking for, you know, a provider for myself, I think it is part of the course to even just think about interviewing a provider to see if they are the right fit for you, and to not hesitate to say, you know, ask them, how much do you know about cystic fibrosis? You know, one question we had was maybe think about asking, does your provider have access to your chart at the CF center that you attend? And how will your healthcare provider sort of know and kind of what's been addressed in your CF center, so that they're not repeating what's been done, but rather complementing? And then, does your provider know about routine care at the CF center versus routine care that is usually not provided by CF clinicians? And does the provider understand about the anatomical differences between women with CF and women without CF? So one thing that's been brought up a lot is how cervical mucus is much thicker and it's in higher quantity than what one may see you know, when they're doing a GYN exam in a woman without CF. And so, you know, these are all important components that I think need to be asked up front, so that you feel like you're going to a provider who really has a good understanding of your disease. And then, you know, in terms of thinking about fertility, so in the general population, when couples stop using contraception, they have an 85% chance that within the next year that they will become pregnant. And that rate isn't necessarily that much lower for women with cystic fibrosis, especially as the CFTR modulators are coming more and more into play. There is certainly some anticipation and concern that women with CF are going to be much more fertile in line with the general population. So fertility, I think, is a really important piece in terms of discussing it and recognizing that, maybe in the past people would think, oh, women with CF are less likely to get pregnant, but that may not be the case as CFTR modulators are more mainstream. So, these are just kind of different stages. And again, these are stages that are appropriate for the general population, and they're much more accelerated for women with CF. But just keeping in mind that fertility is one thing that your provider should be addressing. And then, of course, pregnancy, and I kind of adapted this slide from Jennifer Taylor-Kassar, who I think already spoke to this group about pregnancy. But we know that pregnancy in CF is very, very complex, that, there are a lot of symptoms and sort of diseases that are accelerated or exacerbated with pregnancy in itself and have to be managed during pregnancy. And so although both Sheila and I, in our own ways, Sheila's an obstetrician gynecologist and I'm a family physician who does OB, but I do more low risk OB. Although we take care of patients throughout their pregnancy, I think one thing to be realistic about is that should you decide that you want to be pregnant in the future, that you find a provider who can work with a high risk OB specialist. Because it's probably in your best interest to be working with a high-risk OB specialist during this kind of unique time. And this is just to kind of highlight, and I think I stole this from Jennifer Cannon at Stanford, but it highlights how important it is that if you are deciding, yes, I'd like to pursue pregnancy, that there's a lot of steps that need to be sorted out before you actually become pregnant. So the key thing that I think about when I have a patient with a complex disease, and as their primary care provider, is I really want to make sure that that person has every entity of their disease that's well controlled before they become pregnant. And so I often refer those patients to the high-risk OB to make sure that they have a consultation before pregnancy, rather than kind of trying to fix everything once you're pregnant. And so what's being highlighted here is just the whole conversation around the CF carrier status of your partner. So probably some genetic testing before you become pregnant. What's your pre-pregnancy lung function? Is your diabetes well controlled? What about your nutrition, and what are the medications? Are you on any medications that might be contraindicated during pregnancy? And just being aware that you might have more increased visits to the hospital, and where is that going to occur, and is it going to occur in the same place where you plan to deliver? So these are all really important discussions that when you're looking for a women's healthcare provider, you want to make sure that they understand that complexity, they understand the need for good coordination of care. And then, of course, contraception is a big one, right? So as I mentioned, I think with the onset of CFTR modulators, more and more women with CF really need to start thinking about their ability to conceive. And if the plan is, I don't want to be pregnant right now or at any time in the future, contraception has to be very much a part of the discussion you have with your women's health provider. Contraception in general is quite safe for women without cystic fibrosis. But again, the complexity of cystic fibrosis, I think, needs to be thought through. And you want to make sure you have a women's health provider who's knowledgeable enough about the disease and understands the complexity of CF that they can think, well, maybe in this circumstance, an estrogen-containing birth control pill is safe, but perhaps depending on your history, estrogen-containing is not. So just so you know, we do have some guidance. So we have healthcare providers have some guidance called it's actually called the U.S. Medical Eligibility Criteria for Contraceptive Use. And then there's a sister one called the U.S. Selected Practice Recommendations for Contraceptive Use. And these are their guidance that have come out of the Centers for Disease Control and Prevention. They were adapted from the World Health Organization for the first time in 2010. And they consist of a list of medical conditions, and quite a few medical conditions. I want to say like 68 medical conditions. And for each medical condition, they kind of give you a number. So you can see here a number 1 or a number 2, and then for some a number 3 or number 4. And green, number 1 is green, and that really means it's a green light, meaning like no restrictions. And as you head towards number 4, it becomes a red light, meaning that is not safe to give to a patient with that particular medical condition. Cystic fibrosis was added to this particular guidance in 2016. And I was somewhat involved in the sense that I actually, I had suggested it to the medical eligibility criteria, committee to please add cystic fibrosis. And then a systematic review was done. And I was a part of kind of that review committee with the cystic fibrosis a systematic review. And the sad thing is there were so few articles that have actually evaluated how safe birth control is for women with CF. And so what happens is the CDC has to kind of provide guidance based on the best available evidence. And because the evidence is so poor, these green lights may not always be a green light for you in particular. So, so copper IUD has no hormones at all, so generally would be considered safe. And this is a hormone IUD, which only has a progesterone. The implant only has a progesterone, and this is an implant goes under the skin. And then the progestin-only pills. So in general, when you have progestin, you don't have any, added sort of risk of clotting. But there may be some other things that are unique to you and your disease that would make you less of a candidate. The DMPA stands for the 3-month injectable, the Depo-Provera, and you can see that it has a number 2, which is less of a green than number 1. And so one would ask, well, why is that? And when the committee was deliberating the evidence, and there was one study that looked at 2 people with cystic fibrosis and how well they did on Depo. In some ways, women with CF did very well with Depo because it helped them gain weight, which is very advantageous for this particular community, not so much for women without CF. But the downside is just the concern that after 2 years of use, that Depo can lower your bone mineral density scores. And so in light of the fact that women with CF often take a lot of steroids and take medications that are already kind of impeding on the density, the bone density, there was a theoretical concern that the 3-month injectable over kind of a long period of time may not be the most optimal birth control method to use. CHC stands for combined hormonal contraception, which is the estrogen-containing birth control. So it's a pill, it can be a patch, it can be a ring. And you can see that it has given a number 1, but it's been given an asterisk, which means if you happen to have had a clot with, any kind of port that was placed or any kind of line that was placed in the past, then an estrogen-containing birth control method would not be the most optimal method to choose with that kind of history. The other thing you have to think about when you have combined hormonals, if you have any sort of CF-related liver dysfunction or impairment, because estrogen is it's sort of metabolized through the liver, and can kind of put like an extra sort of stress on the liver. And so there is some concern that maybe the estrogen containing wouldn't be metabolized as well if you already have some underlying liver dysfunction. And then there's also some concern when you have CF-related diabetes. So in general, there is a recommendation, this particular guideline for people with diabetes, that if you have a fair amount, if you've had it for 20 years or you have, any signs of vascular disorder associated with your diabetes, that estrogen-containing birth control is probably not the safest method either. So the point being is that when you're interviewing a women's health provider, you want to make sure that they have some knowledge of these guidelines and can kind of think critically about what methods might be safe for you. So with that, I'm going to hand this over to Sheila.
In terms of finding a good fit in terms of a women's health provider, one of the biggest things that we are hoping that physicians and clinicians are starting to do, and that you should really expect from your doctors, is that the care is person-centered. Some people say patient-centered, or that there's shared decision-making. And this is really having the conversation start with you telling the doctor what is your hope for the appointment. So, one of the things that we recognize is sometimes that the clinicians may not have a great amount of time, but during that time, it shouldn't be the doctor talking at you. It should be you asking, saying, today I want to address this. And sometimes it may mean that the doctor only has, the 15 minutes or half an hour to address one of your women's health concerns. But you can say, today I want to discuss fertility. And these are the things I want to, my questions, and these are things I want to ask you. And then maybe can I have a follow-up appointment where I'm going to, I would like to talk about my contraceptive concerns. So a lot of, really starting off with what are you hoping to get out of this appointment is how we're trying to advocate that clinicians do this. It seems like a very simple concept, but it's something that, gets lost sometimes when in a busy clinic, that it really should be the patient, kind of bringing up what is important to them to discuss. I have a video, but I think I'm just going to put it in the chat because of the sake of time, in terms of kind of an encounter where shared decision-making is being done. It's done by Jody Steinhauer's group at UCSF, and it just has very, aspects to it where there's a lot of dialogue, right? It's not the doctor saying, I recommend this contraceptive method. It's a lot of asking the patient what they're interested in, and then making sure there's a lot of check-ins to see if there's any answers on that need to be addressed. The other big thing that I think is something that is evolving and something you can ask about is if there's a telemedicine option. Our clinic is starting to do this, specifically with women with CF, offering a telemedicine appointment. We know that there is concerns for infection control for you, and perhaps you don't need to come in and wait in that, the waiting area with other people. That this is a new upcoming thing, and I definitely think it's something you can ask about. In the same light, if there is ability to message your doctor, they have kind of an email system called MyChart in Epic, which is an electronic medical record that many institutions use. So instead of having to call a call center or having, if you have a little question, sometimes there's ability to kind of email securely with your physician. So that's something to ask about as well. Another thing with that is some clinics, including ours, have a CF clinic where the doctors come to you. So you stay in the clinic room, and a contraceptive specialist would come and talk to you, and then another maybe a endocrinologist would come and talk to you rather than you switching rooms. So another, just having a center and a clinician that is thoughtful about your concerns for infection control. Other things that are helpful are how easy is it to schedule appointments and cancel appointments and get back in. So, sometimes when you make an appointment with an OBGYN, the appointment's in 2 or 3 months. And you may be sick at that point and can't make that appointment. So is there maybe someone that is more available? We have really wonderful nurse practitioners that sometimes have more availability. And so maybe thinking about that in terms of what type of clinician you see. Also, the duration of the appointment might be important. So if you decide to have a pregnancy, sometimes a high-risk doctor will have a half an hour appointment for prenatal appointments rather than a 15-minute appointment. And that is respectful that it's, there's multiple things that need to be addressed with regards to your cystic fibrosis. So kind of just having, and contraceptive specialist, same thing. When I see a patient for contraceptive counseling, I get a half an hour, as opposed to my colleagues that may get 15 minutes because the women I see are more complex. So, so I think just thinking through that a little bit is a way to kind of be thoughtful about being in a system a clinic that is giving you time and respect for the complexity of your medical condition beyond, some things that should be done properly too in terms of women's health, in terms of shared decision making and having time to do that properly. What we really are looking forward is this next segment now of kind of hearing from you what we can do better. And although we say these are the ideal things that you would see in a healthcare provider, it's true that there's not enough women healthcare providers that are able to offer you all these things we're suggesting. And so, all the things that our group is doing in terms of creating maybe a toolkit for clinicians to know how to do this well. This is a work in progress, and we definitely need input on how we can do things better. And there's things that even from today's presentation that Emily and I probably didn't even think of that you have on your mind that we want to make sure that we have time to talk through and see how we can improve things.